Anterior vitrectomy in cataract surgery. So let's begin with the basics. The entire eyeball is divided into anterior segment and the posterior segment. Anterior segment is filled with aqueous humor, which has water-like consistency, and it's produced in the posterior chamber of the anterior segment and gets absorbed in the anterior chamber. Posterior segment is filled with vitreous humor, which has a jelly-like consistency. Although vitreous is 98% water, this tissue has a gel-like consistency with viscoelasticity. What happens in case of posterior capsular dehiscence? The vitreous moves into the anterior chamber and forms a single compartment. The entire eyeball becomes a single compartment filled with jelly-like consistency material called vitreous humor. Now, the anterior segment is not prepared to accommodate the vitreous. The corneal endothelium, angle structures, they get irritated. It's non-physiological, leads to complications like secondary glaucoma, Bullets keratopathy, corneal opacities, and iridocyclitis. In 1971, this paper published in BJO said 6% of such eyes are lost within a year and usually within 2 months. Now, before we go to the anterior vitrectomy, let's look at the anatomy of the vitreous a little bit more in detail. The viscoelasticity and gel-like structure is because of the hyaluronic acid and collagen present inside the vitreous humor. Collagen fibrils, they're attached, they move from the posterior part to the amylase. They are attached from connecting the anterior and the posterior part of the eye. And the vitreous can be divided as central vitreous, anterior cortical vitreous, and the posterior cortical vitreous. The anterior cortical vitreous is attached to the posterior lens capsule in a ring-like structure called Weger's ligament. At the vitreous base, the collagen fibrils are very adherent to the retina and also the ciliary body. Now, because of this attachment, what happens during the PCR, these fibrils, they move into the anterior chamber and they tug at these structures where they're very adherent, because of which there can be complications like retinal break, cystoid macular edema, and the attachment of the enlargement of the PCR. Now, coming to the management of the PCR, this is one surgery which begins with an epithet dang. In the sense, nobody's prepared. We are all taken by a surprise. One should remember the aim of the surgery, that is to avoid any traffic across the posterior capsule. The first thing that needs to be done is to seal the break, and one should keep the anterior chamber formed, should not remove the phaco probe immediately as a reflex. Instead, inject a viscoelastic before removing the probe, and preferably it should be a dispersive viscoelastic that should be used. One should know how to identify a PCR before one, encounters the uh, one goes for the vitrectomy per se. In this paper published in BJO written by Dr. Ronald Yeo, he described pupillary snap sign of posterior capsule rupture when it occurs during hydrodissection. So, sudden marked pupillary constriction of about 30% was noted during hydrodissection in the pupillary snap sign. And This is what one should look for. If one encounters pupillary snap sign, one knows that one might encounter vitreous at any point uh, during the surgery. Coming to the anterior vitrectomy, the aim is to clear the anterior chamber of the vitreous humor, can approach it through the anterior approach or the posterior approach. So when you take the anterior approach, one can use the irrigation cannula and the vitrectomy cutter, a vitrector, and use two ports to clear the anterior segment of the vitreous, or can go through the pars plana and take the posterior approach. Here one should be a little careful uh, because possibility of causing choroidal detachment, retinal breaks is there, as we know that the vitreous is very adherent in this part to the retina. So this is kind of treading in the dangerous zone, and a trained vitreoretinal surgeon is better able at this approach. Now, coming to the machine settings, one should avoid pressure fluctuations, hence, low aspiration flow rate, the least possible, can be taken, and the maximum cut rate is recommended. Can use cut first, I setting to clear the anterior segment of the vitreous. And if one encounters cortex while clearing the vitreous, after cutting it by using the above setting, can move to IA first and cut later setting. As we know that vitreous is made up of it's basically a colorless jelly, and if one wants to do a proper job of clearing the anterior segment of the vitreous and wants to see it very clearly, one can stain it with triamcinolone acetonide, and it helps in making the surgery very thorough, though one has to be a little careful. I'm like aware of the complications, that is tasotoxicity because of the preservative used, and endophthalmitis, which can be sterile or infectious, and the steroid that's there in triamcinolone is basically steroids, so it can induce glaucoma, and again, because of the preservative, can cause corneal and retinal toxicity. The infections, the use of steroids can mask the signs and symptoms of endophthalmitis. Hence, one should be very, very wary about all these things if one has used this. This drug to stain the vitreous, and the eye becomes more susceptible to infections. We all know use of steroids makes the eye more susceptible to infection. This beautiful paper published in JCRS in 2014, which shared the long-term results of use of triamcinolone acetonide during anterior vitrectomy, says that there were cases, around 15 cases, where this drug was used to stain the vitreous during anterior vitrectomy. None of the cases had these complications of persistent corneal edema or glaucoma or retinal detachment. Two patients, though, did develop cystoid macular edema. With that, I thank you for listening to this talk on anterior vitrectomy.